Greetings and welcome to Mental Health Trailblazers, Psychiatric Nurses Speak Up. I am your host, Indrias Kassaye, and you are listening to Season 2 of the SAMHSA Minority Fellowship Program at the American Nurses Association's podcast, where we spotlight MFP fellows and alumni and their pioneering work to improve health outcomes for marginalized communities. We have so much to explore, so let's get started. Greetings, Dr. Bonds Johnson, and welcome to Mental Health Trailblazers, Psychiatric Nurses Speak Up. Thank you for joining us on this beautiful spring day. If I can start with asking you to introduce yourself to our audience.
Hello, everyone. I am Dr. Kalisha Bonds Johnson. I am an assistant professor at Emory University's Nell Woodruff School of Nursing and a psychiatric mental health nurse practitioner at the Integrative Memory Care, which is an entirely dementia-friendly primary care practice, also at Emory.
And tell me, why did you decide to become a nurse, and a psychiatric and mental health nurse in particular?
You know, that's an interesting story because I initially wanted to be a doctor, a physician, because I thought they made a lot of money and helped people. And so I've always been really good at science and math. And so I wanted to go into the medical field, but started out as pre-med. And during, I think it was my sophomore year in college, I had a really bad burn to my leg that required that I go to student health every Monday, Wednesday, and Friday for an entire semester or term. And during that time, I quickly realized that the doctor was like in and out, but the nurse stayed with me, and I learned who she was, and she got to know me, and we actually became friends. She invited me to her wedding that happened later that year. And that rapport building for me was like, no, forget being a doctor. No offense to my physician colleagues. We love you. But I love the relationship building that I engaged in with the nurse.
And then why particularly a psychiatric and mental health nurse?
I think it's my family of origin. They often tell me I'm the glue that holds the family together. And so wanting to understand other families and dynamics and the context of family, there's just no other, in my opinion, nurse practitioner opportunity program that allows you to look at things holistically and look at context. And I've always been interested in psych. Most nursing students are not. There's usually like a handful of us that kind of hide in the back are like, yeah, we really like our psych class, because most people go into nursing for mother and child, or to do, labor and delivery, or cardiac, or, those sexy and exciting things. Sometimes psych isn't always seen that way, or mental health. And so I have always just really been interested in learning more than what we could figure out through labs. Mm-hmm. And so I think it fit nicely.
But you didn't stop at just being a nurse practitioner. You've taken it all the way. And what made you pursue academia further?
I don't know. I'm crazy. No, really, every time I got a degree, I was like, I'm done. Like I received my bachelor's. That's it. I'm never going back to school. And then it got to a point where I ended up working on an adolescent medicine floor at Vanderbilt Children's Hospital. And any patient that came on the floor, I felt comfortable taking care of them, and I didn't really feel challenged. And I was like, nope. Let's see what else we can do. And so then my desire and love for psych and mental health and family allowed me to pursue my PMHNP, or Psychiatric Mental Health Nurse Practitioner degree. And I worked in long-term care facilities, so like nursing homes, assisted living facilities, and realized that we really, as staff, as a community, as society, really didn't know how to help these families who had loved ones and family members and friends who had a diagnosis of dementia. And when I would talk to them about different resources in the community or different things that they had tried, it just seemed limited. Like they didn't know about resources. And by the time they got to me in a nursing home, it's really too late to tell them about resources to help keep the family member at home longer. At that point, they're being placed long term. Mm-hmm. And so it bothered me. It bothered me enough that I was like, you know what? I think maybe I should go back to school one more time. And so here we are.
Well, it's been quite a journey. And I know that you finished your doctoral degree and recently joined Emory University. In its announcement of your joining the School of Nursing as assistant professor, tenure track, congratulations.
Thank you.
They said Dr. Bonds Johnson hopes to improve health outcomes for African-American persons living with dementia and their families through the development of culturally tailored clinical interventions. So to start this discussion on dementia off, how big a problem is it within African American communities? And is this significantly different from, say, other ethnic and racial groups? Why you've decided to focus on African American families?
Great question. I will say overall, when we think about older adults and the cause of death, dementia is the fifth leading cause of death in all older adults. I think that might be within the United States. And so what we do know, especially the work that's come out of the Alzheimer's Association, is that African Americans are suggested to be 2 times more likely to develop Alzheimer's disease when compared to their non-Hispanic white counterparts. And then Hispanic individuals are 1.5 times more likely to develop Alzheimer's disease when compared to their non-Hispanic white counterparts.
And why is that?
I think there's a lot we don't know, but because when we think about the brain and blood supply, and not necessarily Alzheimer's disease, but vascular dementia, which is a type of dementia that falls under that umbrella of dementia or Alzheimer's disease and related dementias, our blood supply is really important. And so when you think about things like diabetes, hypertension or high blood pressure, stroke, those diseases can impair our blood supply to our brain. And so we see things like a vascular dementia more common. With Alzheimer's disease, the number one indicator or risk factor is age. So the older one is, it increases one's risk for Alzheimer's disease. There is what we call like a late stage. Again, that's the one that we typically see in older adults. And then we have an early stage, which is individuals who are sometimes in their 60s. That one is more genetically influenced oftentimes. And
are there concerning trends that we're seeing over recent generations? And I ask this because just anecdotally in my own sort of networks and community, I'm hearing more and more friends who've had to take care of their parents and see this really debilitating illness take over. So it seems to be something that's increasing, but is this something that you're seeing more of?
People are living longer, so it wouldn't be uncommon that we are seeing an increase. The other thing is I think we're looking forward to, where in previous generations, if someone was senile or people sort of overlooked it and just associated that with them just getting older. I think we are a little more aware of what Alzheimer's disease and other related dementias look like. And so we can maybe pinpoint it a little easier, identify it, diagnose it more so than it was years ago. But again, we are living longer. And because age is such a huge risk factor, I think that's a part of it as well.
Part of your focus is working with families. What does treatment look like today with regard to persons living with dementia and their families? And how are nurses trained to deal with the whole dyad, I guess, as you call it, in the science, but the caregivers as well as the people who are living with dementia? Why did you decide to focus on this whole?
That's a lot to unpack. So I think the easiest part is because I grew up with an older adult. My grandmother is, I'm probably going to get this wrong. She is 87, I think. I was 2 years old when my mom passed away, and my brother was 9 months. And so in her 50s, she gained 2 grandchildren and raised us as her own. And so I've watched her age over the years, and, I don't see how people can do research with older adults, especially individuals with dementia, without considering their family context, if they have one. I mean, we all have a family, but some people are closer to others, closer to family members than others. And I think that holistic approach, it matters. It matters when we think about how we want to intervene or what strategies we want to put in place, whether someone has someone living with them or someone that's a phone call away or has no one. And so I didn't think we could look at these African-American older adults without considering the context of who's providing most of that care. And it is different when we look at that within African-American families compared to non-Hispanic white families. So in your non-Hispanic white family, it's typically spouses that are caring for one another, where in our African-American community, it's typically adult daughters who are doing most of that caregiving. I will also say a lot of adult male children are also getting involved, but the large bulk is is the adult daughter. And so that dynamic of being an adult daughter caring for your parent is already different from a spouse caring for, a husband or a wife. And so with it, it just creates, I think, opportunities to culturally tailor interventions so that we're really getting at the lived experience of these caregivers.
When you're presented with a patient, your treatment, your diagnoses, the processes that you go through are directed and focused on that patient, on making sure that that patient is taken care of and that their outcomes are good. But reading some of your research, it seems that you are looking beyond that now and perhaps identifying another group of potential patients that need to be cared for and that perhaps the health system is missing. If you could tell us a little bit more about that.
I think there has been quite a bit of work done on caregivers. So we know quite a bit about caregivers or care partners of persons living with dementia. We didn't know as much about the dyad. And so that was kind of the piece that I added, in the sense that I don't just want to focus on the caregiver. I also wanted to focus on the person living with dementia. And so a lot of that caregiver research or care partner research is showing that persons who provide care for someone with a diagnosis of dementia or Alzheimer's disease and related dementias, I'll probably just lump it all into dementia in this podcast, actually sometimes die before the person they're providing care for.
Why?
Honestly, I can't imagine how individuals do it. Like, I'm a distance caregiver to an extent of my older grandmother, and she doesn't even have dementia. Like, I cannot imagine the amount of hours and time and effort and energy and guilt and long suffering and patience that goes into wanting to make sure that another adult human being is well cared for and receiving all the treatment that they need and having the best quality of life that they can have and it not affect your own health. But the healthcare system needs these people. We need care partners and caregivers and family members and friends and neighbors to continue to do this work. It saves the healthcare system billions of dollars when you have someone else that can provide care for them outside of the healthcare system. Also, the healthcare system really isn't set up to provide such care. And when we have individuals that have a care partner, caregiver, family member, friend, network, social support, oftentimes they can stay in their homes longer before having to be transitioned into a long-term care facility.
That's a fascinating fact to hear here, that people who are caring for somebody with this terrible chronic and debilitating condition are suffering perhaps even more than the person who is sick. And you see that in that they're dying sometimes earlier than the person that they're caring for. Going back to one of your earlier points about the importance of culturally tailored interventions, what are these and why is it so important that they are culturally tailored?
So I don't know what this culturally tailored intervention will be. I am still quite early in my research career. I did graduate in 2019. I did a postdoc at Emory from 2019 to 2021. For anyone that doesn't speak research lingo, a postdoc just means I did some additional training after I received my doctorate. Mm-hmm. And so I recently received a grant from the National Institutes on Aging in 2021. It's a 5-year grant to help me come up with this culturally tailored intervention, using some community engagement approaches to where I'm actually going to these individuals, these AfricanAmerican persons living with dementia, their adult daughters, and working with them to figure out what it is they need that we can co-create and hopefully make some changes in how these families navigate the healthcare decision-making process for a parent living with Alzheimer's disease and related dementias.
Well, now I'm going to ask you for a call to action, because it seems like this is a really big problem, and perhaps you can tell us the extent of the population in the United States that is affected by Alzheimer's, by dementia, and what the size of the caregiving population is, and then what the cost is for not taking care of the care providers.
It's an estimated 6.5 million Americans aged 65 and older are living with Alzheimer's disease in 2022. 73% of these are 75 years and older. This is coming straight from Alzheimer's Association, some of their facts and figures. They put a report out every year that is just full of information. And so I truly enjoy seeing some of their facts and figures just to get an idea of what's happening. And then when we think about how many people are providing care, I mean, it's millions of people that are care partners and caregivers. And again, I think it's $257 billion or so of unpaid dementia care.
Wow.
That these care partners and caregivers are doing. And so again, it is no small feat. I guess if I had a call to action, it would just be, for people to get involved and either in your communities with research. I'm really trying to push even my family to be involved in research. Like, we need to hear what people are saying. We need to hear what's of interest to you and how we can support different families and communities. But we won't know if people don't get involved in research. And actually, underrepresented minorities are often less likely to be in some of the research. And I'm not going to put all the onus on the community members and the partners. There's a lot of research being done that isn't thinking about diversifying their sample population, even if they say it in their grant application. And so if you're not being intentional about being inclusive, you're probably being a little exclusionary.
And looking at the research that's been done on African-American communities, African-American families, what is your take on the approach, and how do you think you will do it differently and perhaps contribute to the better outcomes?
Yeah, I think this happened when I was in my PhD program. So I knew I wanted to focus on dementia. I knew that was a given because I had seen firsthand in long-term care facilities that we just didn't know enough. We didn't really know how to support these families sooner, better quality. There was just things lacking, missed opportunities, as I sometimes call it. And when I started reviewing the research, it just seemed like some of the researchers didn't really like Black people or didn't really know Black people, and not to say that Black people, African Americans, are a monolithic group. We're actually very diverse. But unfortunately, in research, we do a terrible job of highlighting how diverse and heterogeneous individuals are. And so we lump all Black African Americans in one category and all Asians in another category and all non-Hispanic whites in another category. And we examine across these groups and we feel like we've come up with the answer. And to some extent we have, but it just felt like there's so much variety in this group. Most of the research was constantly comparing African Americans to non-Hispanic whites. And I find that to be problematic because in America, we live in at least two different Americas. Like, my lived experience is different from my non-Hispanic white counterparts' lived experiences. And so to not take that into account when we're examining data, when we're interviewing individuals, is a disservice to the group of people, the sample that you're then generalizing to a much larger group of people. And so that bothered me. So instead of comparing, in my own work, I don't compare. I look specifically within African American, Black American individuals to see what is unique within this group, not comparing this group between groups. I'm curious about what's going on within the group. And when I did that, and part of the reason I focus on adult daughters now is that in some of my dissertation work, it came out that these adult daughters, so I had adult daughters and predominantly spouse care partners, caregivers. Mm-hmm. And the adult daughters, as well as the person living with dementia that they were providing care for, had worse quality of life than those who were cared for by a spouse in the Black community, which is not something we typically see in the literature. In the more dominant dementia literature, it says that spouses, who are typically non-Hispanic white spouses, had worse quality of life. And so again, if we're focusing on what we see as the larger group and not really thinking about the specific African-American experience, we would miss it. If we tailored it to spouses, we'd miss it because the majority of adult daughters are providing care in African-American and Black American communities.
Another part of your research is also looking at the interventions that the research suggests would work. What I found really interesting was you said a lot of times the research on African-American families and communities and the interventions that are suggested look at the weaknesses and at the
deficit perspective.
Yes. Instead of the strengths.
Yes. Again, I spent a lot of time in my PhD program trying to find the right theory and trying to understand how I was going to frame the research, and came across this book that's The Strengths of the Black Family. And so it was like these 5 strengths. And I'm like, oh my goodness, who knew this was around? I mean, I know a lot of people knew it was around, but when you're in nursing, oftentimes they want you to focus on nursing theories. And I found that the theories in sociology and psychology just spoke more to what I was looking at and how I wanted to look at these individuals nested in families, nested in communities, nested in societies. And, some of the strengths were the idea of kinship bonds and caring for someone, caring for family, which of course then resonated with my desire to really want to look at the families and not just one individual. The idea of, sort of like surviving, pursuing an education at all costs, like the grit and the really just determination that we as a people have in wanting to be successful, spirituality and just really having belief in a higher power and, just all these different things that really came together and sort of made sense to me. And I was like, yes, this is great. Let's bring this in. And so, when we think about interventions, which is such a researchy term, it really is just coming up with strategies, tools, programs, aids that help people do something, that makes it easier to do something. And so, I'm excited about what that will look like in my work. I definitely want to do more community engagement focuses and approaches. I'm currently in a class right now that's that really talks about co-creating research and letting the community own part of the research and like have a say and be on the payroll and, all these really neat things that we can do for individuals so that we're not just doing research on them, as it was said today in class, but we're doing research with them, with the community, which makes me excited. Like, as a tenure track faculty member, would love to get tenure. But if I truly make an impact in the community for good, what a win. And so that's really where I'm at right now. It's still early, still learning a lot, but I'm thrilled about the journey that I'm on.
And we're thrilled to have you with us, Dr. Bonds Johnson. And we'll be right back. You are listening to Mental Health Trailblazers, Psychiatric Nurses Speak Up, brought to you by the SAMHSA Minority Fellowship Program at the American Nurses Association. You can learn more about this unique program that provides support for psychiatric and mental health nurses from underrepresented backgrounds pursuing their master's and doctoral degrees and how to apply at emfp.org or email us at mfp@ana.org. Welcome back.
Thank you.
So Dr. Bonds Johnson, we've been talking about some pretty heavy stuff. So I wanted to lighten it up a bit and ask you in perhaps tweet size sound bites a couple of questions. So let's start this off with.
Have you ever heard me talk? Sound bites? This is going to be terrible. Okay, I'm ready.
All right. Number 1, who is your nursing hero and why?
Oh, nursing hero. I'd probably have to say Dr. Susie Adams at Vanderbilt because she is the one who I found the research bug because of her. She said I'd been bit by the research bug.
And the best part about being a nurse?
Only having to work 312s when I was a nurse on the floor.
And the worst part?
Having to work 312s while I was on the floor. No.
All right. And then your most awkward moment as a nurse?
Oh, being asked to put cream on an older gentleman's genitals.
Okay. All right. Now looking at the way society views nurses, and here when I say society, I mean just the general public, media, other health professionals, what are your biggest pet peeves?
That nurses are sleeping with doctors at work. Like, we have so much work to do. I mean, I need there to be at least one medical show that does not have us taking our clothes off in the medical cabinet or wherever they have it. I mean, like, I was busy. I mean, if anything, I was trying to get a nap, and that wasn't even possible. Like on your little break, you tried to get a 15-minute, 30-minute nap. Nobody has time to, yeah, moving on.
One piece of advice that you wish someone had given you while you were in school.
That imposter syndrome is real, but that you are there because you are supposed to be there. And to own your voice and speak up.
Okay, for people who might not know what imposter syndrome is.
For people who don't know what imposter syndrome is, the best way I can describe it happened when I was accepted into the PhD program. Most days I would feel like somebody was going to come in and tap me on my shoulder and say, Miss Bonds, because I wasn't married at that time, we need you to leave. We accidentally allowed you into this program, and that was a mistake. So the idea of feeling like you're not meant to be wherever it is that you are is kind of how I describe imposter syndrome.
You alluded to the stress and the great amount of work that comes with being a nurse. What are some of your favorite comfort foods?
Oh, anything sweet. Butter and sugar are my favorite together. So cupcakes and brownies and chocolate.
And you could cook?
Stop. No.
No? Your
I
husband?
am from the South, and I tell my husband all the time, who is from the Pacific Northwest, that he did not get a Southern cook. I'm really good at ordering, though. Like, and you know, it doesn't bring me joy. It's not something I truly enjoy doing. My grandmother's an amazing cook, and she would often tell me to come in and learn from her and see what she was doing. I'm like, Granny, I'm doing homework. Granny, I'm working. And now I'm like, Granny, hello, can you help me? And she's like, you know, it's a pinch of this and a tab of that. And I don't know what that means. I need real measurements. So no.
And we are hopefully coming out of this really long period of COVID-related stress and lockdowns and all sorts of things. And during times of stress, we sometimes find out new things about ourselves. Anything that you discovered about yourself?
That I didn't know how to turn work off at first. Because usually before COVID, you had to get home. So I would drive to the shuttle lot. The shuttle leaves at a certain time. I need to leave campus at a certain time to catch the shuttle to get home. But when there was no leaving home, I was just working and working. And my husband was like, knock on the door, like, are you coming out for dinner? Are you gonna spend time with me? And so that was probably the first thing I had to learn, was how to turn things off when there is no like official cut point in my day.
Have you dealt with that?
Yes, I'm much better now. So I actually took a course at Columbia, the PI crash course. Mm-hmm. And one of the people was talking about time management and how he used his calendar as his to-do list. Because usually I would have a to-do list, but I didn't necessarily have it plugged in with hours and minutes associated with it. And it's amazing, once I did that, it kept me on schedule. And so I'm able to stop at a certain time, for the most part, when I need to.
No, that's a great practical tip. Well, thank you very much for those. And we will be right back. You are listening to Mental Health Trailblazers, Psychiatric Nurses Speak Up. There is a critical need for students of all underrepresented ethnic backgrounds to pursue graduate degrees in psychiatric mental health nursing. The Minority Fellowship Program at the American Nurses Association is a federally funded program designed specifically to provide fellowships and mentoring support to students from all underrepresented ethnic backgrounds pursuing master's and doctoral degrees in these fields. Visit emfp.org to learn more and apply. Dr. Bonds Johnson, when we met at the Minority Fellowship Program's Tallahassee Intensive Training Institute in 2019, you reflected on what it meant for you as a person of color to be among other scholars from underrepresented backgrounds. Let's take a listen.
This was the first time I've ever been in an academic setting with a group of minorities. I've never had that experience. From kindergarten through my pre-doc program, I've never had the experience of being in a room full of people that get it, and I don't have to explain it. I was very nervous about coming here and didn't know if I had anything I could offer, but just was really ready to receive. And so I'm grateful and I'm thankful for this opportunity. I don't get this, I will be very sad to go back to Portland, Oregon, where they look at me like I have two heads because they don't see Black people enough. But I'm excited to know that I will have you all as contacts and connections, and I need to get some more Twitter information and make sure I follow up and do that. And I'm excited to be a part of the alumni and to see what I can add and how I can help.
You remember that?
Wow. Yeah.
Yeah. Well, behind your words are powerful emotions. And, I remember being very struck by that and never forgot. And so I bring it back, now like 3 years later. But if you could tell me more about the backstory behind that, including, what it was like being an N of one, as it were, and how that affected your journey through academia.
Yeah. Wow. Sorry. I'm remembering the moment. There still hasn't been a moment like that outside of that moment to this point. That was just I remember I was so annoyed, though. Let me give you the true backstory. I was so annoyed that I had to go to this institute initially because it was at the exact same time as our Western WIN conference, which don't ask me what it stands for now, but I do know it was a regional, I think, nursing conference that I was supposed to go to and present my research. But this was mandatory. And so I had to come. I had to go to Tallahassee for this institute. And so I was so annoyed. The first night I sat in the back of the room. No one probably knew that I was annoyed, but personally I was annoyed. And so I just was kind of like, we'll see. We'll see. Like, what's the big deal? And as each day went by, I met another individual and another individual and another person and more people, and was constantly in rooms with people of color, of all different personalities and identities, and it was beautiful. And I felt so guilty. But being upset when I initially went there. But, to this day, I still am not in spaces where I'm not one of a few. In elementary school, there were 6 of us, I think. And so they would divide us 2 in a classroom. In pre-K, I think I might have been one of a few, maybe even the only. In my PhD program, I was the only Black student local. There was a Black student, but she ended up graduating before. So there was a moment where I was the only Black student. We didn't have any Black faculty in the School of Nursing at OHSU. The one Black faculty we had retired right before I came, but she did make some time for me outside of it. And I didn't realize that I needed those spaces because I had never had those spaces. I had never had a space where, like I said, I didn't have to explain it and people got it. Where I could just be myself, where I could switch between being completely comfortable Kalisha and professional Kalisha, all in, with the switch of a breath or the turn of a head. Like, I will forever be grateful to MFP for that institute, for that opportunity, and for the continued opportunities that they give me, because spaces like that don't happen every day in America. And yeah, I'm just grateful.
It's a sad reflection of how things are in this country that you feel the loss of that. I mean, you might live in a community that doesn't have many Black people, or whatever race you might be, that there might not be many like you, but you should still feel comfortable. We're all people. You should still be able to feel like you can be yourself and not have to have any sort of shell or layer or, some sort of protective shield that you put up. And it's interesting that you recognize that when you were immersed in a place where that was not necessary. But of course, the reality being the way it is, what would you suggest then for schools to perhaps adopt in the learning environment that would make it better for students from underrepresented communities? Not to feel that they have to code switch and to feel comfortable in their own skin.
Oh, that's a big lift. Because unfortunately, most schools still put the onus on the individual to do something, to make a change. I remember when I first started at OHSU, and not to knock them. It was a great experience. I learned a lot. I have some great mentors from there and colleagues and friends, but I often got asked, how do we get more Black people here? As if I had that answer. I don't know. I can only tell you my experience and how I ended up here. And so I think, just recognizing that even if you bring in people of color, everyone is different. And we have different identities of both privilege and of oppression. And so because of that, you can't assume that a one-size-fits-all DEI approach is going to work. I think people really have to put their money where their mouth is. It'll be interesting to see because 2020 happened. And so now schools and communities and organizations are, I feel like they found every stock photo of a person of color that they had stored somewhere and have now started putting them on every poster and flyer and website. But it will be interesting to see if we go beyond that sort of superficial representation and really get to wanting to change culture. Because you can bring people in, but if they don't feel supported, reassured, comforted, they won't stay.
And now that you've completed your PhD and you're teaching, you're on the tenure track at one of the leading health science universities in the world, how are you navigating the challenges of racial representation in academia?
I'm constantly working on self-reflecting. While I can understand racial identities, I will say that I have ignorance or lack of understanding when it comes to gender identity, sexual orientation and identity. And I'm really working on trying to make sure that I, understand one's pronouns and try to use those appropriately and understand that things are changing, and really just try to meet people where they are, recognizing that I'm going to mess up and make mistakes, but owning those mistakes and apologizing immediately and then trying to rectify that change. I think if we did that across identities of difference, that we recognize that this is what I know, this little bit right here, and that with what I know, I'm sometimes going to make mistakes, and I can own my mistakes, and I can apologize, and I can make a change to be better the next time around. But sometimes people don't want to have the conversation. And so I'm grateful to have trusted allies in lots of different identities where my identity might be considered an identity of privilege. Like because I'm heterosexual, that's considered an identity of privilege, where my other counterparts who aren't have an identity of what we would maybe consider oppression or whatever, or lack of privilege. And so recognizing that you just need a lot of different people at the table to learn from and to grow from is really what I'm trying to do. Just my circle is full of different people who have different identities and values and views. And we can come together and have discourse and have conversations. We don't always agree, but I can learn from them and they can learn from me. And I think if we really genuinely did that as a people, this would be a much better place.
I wanted to ask you, as a closing reflection from you, when I reached out to you about the kind of subjects or issues that you wanted to focus on for this podcast, your first response was your grandmother and the influence that she has had on your life. What does she say now? She raised you from you were very young. Yeah. What does she say now that she sees you, Dr. Kalisha Bonds Johnson, tenure track professor at Emory University?
What does she honestly say? What do you do for a living? Because in her mind, a doctor is a physician. And so she did tell me that they were hiring at the local hospital.
Okay.
In case I was curious. But no, I love my grandmother. She instilled the importance of education in us at such young ages. And managed to get her high school education, even though she had to move in with another relative and walk to the school to get it. I quickly learned, though, growing up with her, that we got to a certain point, like, you put your homework out and she would review it. And then it got to a point where she was like, baby, I can't help you with that. But she was there and is still there and will tease me anytime she gets like a research opportunity in the mail. She's like, I don't do that. You do that. You do the research stuff, baby. I don't do the research stuff. And I'm like, Granny, we need you to do this is why we need you to be a part of the research. She's also a part of my community advisory board. She doesn't know it though. Anytime I'm getting ready to put a flyer up or post something or think about how I would want to recruit older adults, I run it by her. Like, what do you think about this? I remember when I first started doing dementia research and I was like, I'm really interested in this. And she was like, don't put dementia on your flyer. And I was like, okay, well, what should I put? Confusion, memory loss, forgets sometimes, but don't put dementia on there. And so, even in her humor and her honesty, I just love my granny. Anybody that knows me knows that you're going to hear a story about my granny because she really is my best friend outside of my husband. Can't say, I got to include him. But she just...
But that's really good advice.
It is really good advice. And I don't put dementia on any of my flyers because, it does sometimes have a negative connotation and negative stigma across communities, but especially in the Black community. I remember hearing, and I forget who it was now, but it was a lecturer talking about when you think about the Black church and when we have testimony service. And so if you haven't attended a Black church, that's where you can stand up and kind of give thanks for what's happened or went well in your life, something you've overcome. And one of the things that we often hear in the Black church is, I thank God for being in my right mind. Like that's one that you constantly hear. And so the idea of dementia being that you're not in your right mind, I didn't even think about how it runs deep within, or, in contrast to how many Black people have been standing up in churches for years, giving honor and glory to God for this thing. And here we are talking about something that would be in contradiction to it.
Thank you for that, Dr. Kalisha Bonds Johnson. It's been a pleasure speaking with you. Thank you very much for giving us your time today. And we look forward to talking again sometime soon.
Thank you. Thank you for having me. It's been a pleasure.
And that does it for this episode of Mental Health Trailblazers, Psychiatric Nurses Speak Up. I hope you've enjoyed our discussion, and I look forward to you joining us on future episodes. This is the Minority Fellowship Program at the American Nurses Association podcast, featuring nurse scientists addressing the psychiatric and mental health issues affecting underrepresented communities across America. You can always find us online at emfp.org and wherever you get your favorite podcasts. The views expressed by the speakers and host do not necessarily reflect the official policies of the Department of Health and Human Services, nor does mention of trade names, commercial practices, or organizations imply endorsement by the U.S. government.